Okay. Well, thank you all for coming to this very special conversation with two amazing people. My name is Laura Blasky, and when Aline and Daisy asked me to help by moderating this discussion, I was honored, not just because I'm so proud of both of them for telling their stories, and not just because I'm married to one of them. Guess which one? I don't want to give anything away, but it rhymes with schmazy. Really, I was honored because this is what public health is all about, and I'm proud to be a part of it. Working at the Department of Health is different from working at almost any other state agency because we all have a personal connection with our agency's mission, health. Everyone in this room, in this agency, has their own health story, whether it's a friend or a loved one or you. And on that very organic and basic level, we all know what we're working for to help improve the health of our friends, our loved ones, ourselves, and the people around us, whether we know them or not. Public health is personal. I know Aline and Daisy want to hear from all of you, and there will be time at the end for some questions and stories. But they each have a very personal reason for wanting to do this, and so I'm going to ask them to start our conversation by talking about those reasons. And Daisy, let's start with you.
Okay. So I need to check this. Can you hear me? Not really.
We're having video or sound
Issue? Does this work?
Yes.
Okay. We'll just pass the mic back and forth. Okay. Why am I doing this? First, I want to be clear that we weren't asked to do this. So this was something that we wanted to do. First was because I wanted to say thank you. It is rare to work in a place where, for me, one, I feel safe enough to do this, and two, I was so supported during my entire experience with cancer that is ongoing. The second reason, when I was reflecting on this, was around my identification or not with the word journey when it comes to cancer. So I never really liked the word journey. People use it a lot with cancer until I started thinking about my answer to this question. And the visual that came to me was that all of us were on this hiking trail, and that sometimes there's something really serious that happens, an illness or a death, and one of us goes off the trail on our own path. And that path is full of blackberry bushes and crevasses and beauty too. And some of us don't come back. And I came back. And I feel like there's this unspoken rule where when you come back, people feel like they can't ask you, where were you? What happened? What did you see? And so I feel like I want to tell you where I was. And we even had slides. It's like a slideshow. So I want to show you where we were, where I was, not only for me, but I hope it's helpful for you too.
And the reason I'm doing this is mainly because Daisy asked me to. And I've always had a hard time saying no to Daisy, to be perfectly honest with you. But probably another part of it is, with the experience I went through, I just wanted to forget about it. It feels like a nightmare, and reliving it is like reliving a nightmare. But that being said, it has also been very, for lack of a better word, and I don't think this is probably the right word, cathartic, to actually, send Daisy the pictures and figure out what we want to talk about. And I think part of the other reason is that Daisy and I connected. I just looked back last night, and the first text I got from her was April 4th of last year when I was in ICU. And that was the first text I got from Daisy saying, I heard you're sick, I'm so sorry. And we never really stopped after that. And we've been in touch pretty constantly since that event.
So this is new and very personal, and we did have some disclaimers that you guys wanted to do before we got started.
You bet. I'll take care of that, Laura. What we really want to be clear about is every single person's experience with cancer is unique, and we in no way, shape, or form want to say, hey, we're representative of everybody who's had cancer. Our stories are similar in many ways and different in many other ways, and we know that that's the truth overall. And many of you may have had an experience with cancer. According to the American Cancer Society, 1 of 2 men will get cancer in their lifetime, and 1 of 3 women will get cancer in their lifetime. So we know that, it will touch almost everybody in this room by the end of our lives. I think the other thing that I looked at is that in 2016, there were over 37,000 cases of cancer, new cases of cancer reported in Washington State. Daisy and I are 2 of those cases, but there were many, many others.
So Daisy and Elaine have also set this up to align with one of our foundational models in public health, and I think there's a new PowerPoint slide. Daisy, do you want to go ahead and explain?
So the socio-ecological model, for those of you who know me, is my favorite public health model. And I'm not just saying that because John's in the room. It really is.
We have it printed on all our walls. She needs to use this one.
Yeah.
We're having mic issues. So the socio-ecological model is one of my favorite models because it really makes sense to me about how our health is influenced by all these different layers and levels. So for those of you who aren't familiar with the model or don't know a lot about it, we do have it on the screen. I'm sorry we can't show this screen with that, so I hope you all can see that. But the model's really intended to show how our health is influenced by these different levels and the relationship between those levels. So for example, how my knowledge, attitudes, and behaviors are impacted by my relationship with Eileen, my relationship with Laura, that I work here at the Department of Health, what my community is like, and really what is going on in our state in terms of policy and budget. And that also I have an opportunity to affect those things as well. So we're going to be going through our questions kind of related to that model, and the slides will go through and show you where we're at.
So each of you had different cancers and at different stages, and it might be helpful to give an overview of your diagnosis and treatment. Elaine, do you mind starting?
Thanks. I was actually diagnosed when my spleen ruptured in April of 2016, and spleens don't spontaneously rupture, so there was like, what's going on there? And I found out probably about 7 days later that I in fact had lymphoma. I really didn't know very much about it. I didn't know much about what was actually happening to me, and I knew I needed to see an oncologist. So I went to the Seattle Cancer Care Alliance and actually had my first visit with my oncologist on April 20th, when I learned that the kind of lymphoma I had is non-Hodgkin's lymphoma, diffuse large B-cell lymphoma. And so when you think about lymphoma, it's a cancer of the lymphocytes, so it's a blood cancer. And the most common kind of cancer is, the most common kind of lymphoma is non-Hodgkin's. And the most common kind of non-Hodgkin's is diffuse large B-cell. It's, the older you get, the more likely you are to get it. I think there's like, something like 7 out of 100,000 people will get this kind of cancer in their lifetime. The average age that you would get it is 64, and I was 63 and a half when I got it, so I was right on. It is definitely more common in men than women. There's no genetic connection with lymphoma, so I have a daughter, unfortunately, that's not something she's going to have to worry about unnecessarily, so there's no genetic predisposition. So anyway, hang on a second. Okay. So I think what is important to know is that most of the time people are diagnosed with diffuse large B-cell lymphoma because they have a lump, or they have some kinds of symptoms, like they have excessive sweating, or they have fatigue, or things like that. I really didn't have any of those symptoms. I went for a hike in Point Defiance, though probably 4 days before my spleen ruptured. I was in Hawaii about 2 weeks before my spleen ruptured, so I really didn't have any symptoms. Part of what happens with this type of cancer too is that you don't actually, most people aren't diagnosed until they're stage 3 or 4. 70% of the people who get this kind of cancer are cured. I dropped down to 50% because I had stage 4. It was in my bone marrow. So when I saw the doctor, he said, you've got a 50% chance of making it. So if you're sitting there, it's a very surreal experience to hear that from your provider. The treatment, how they say something like the cure is worse than the disease. In many cases, that was true with me. The most normal way or common way of treating this is through a regimen called R-CHOP. And that's an infusion that you would get every 21 days times 6. But because my cancer was really aggressive and it was stage 4, they put me on a different regimen called R-EPOCH, which required me to be hospitalized for 4 to 5 days at the University of Washington every 21 days. So I was at UW for 4 to 5 days. And I didn't pay a lot of attention to my hospital bills. We'll get into this a little bit later when we get into policy. But I opened one and that each stay was roughly $80,000. So just imagine if you were uninsured. You can imagine how popular I am with PED right now. One of their high-cost employees. And so anyway, I had three rounds of treatment, and then I had a complication that was a neurological complication. And so they had to switch my regimen down to the R-CHOP instead, so that became an infusion then every 21 days, and that's just 4 to 5 hours it's all relative, right? Just 4 to 5 hours versus 4 to 5 days in the hospital getting infused. And so my treatment was completed in August, and I had a clear scan in September, which was a very joyous occasion. I see my oncologist in Hemplet work done every 3 months. My next time there is in June, and I will have a repeat scan and other things in September that will include an echocardiogram because chemo is tough on your heart. So the risk of reoccurrence is highest in the first 2 years after diagnosis. So they'll be watching me very carefully during that time. And reoccurrence is a really bad thing. So I'm hopeful that that does not occur. So I think looking at treatment for the future, immunotherapy is going to be a major way of treating B-cell, which is a really good thing because chemo still feels very primitive to me.
So I had started getting mammograms when I was 35 because my mom had breast cancer at 42. But she had ductal carcinoma in situ, which is in the cancer world, they call that stage 0. She had a lumpectomy and did not have, knock on something, she's been great. She didn't have chemo, she did not have radiation. It was pretty much for her, because she had 2 prepubescent kids, a kind of a non-event. So I was actually showering, not doing a self-exam. Something didn't feel right in my breast. There was a mass, and I went and scheduled an appointment with my regular provider, and she did a breast exam, and she said, we need to get you in for a diagnostic mammogram. I think that was the point that I told my bosses, Dan and Jana, because I was terrified that it was cancer. And then on April 15th, I had my diagnostic mammogram. It was a Friday. Laura was with me, and the radiologist said, "I'm sorry, but I'm pretty sure that's cancer." So it's hard to hear that on Friday afternoon. I spent the weekend calling people and letting them know. And then things just started to unfold from there. At first, we just thought I had the same cancer that my mom had, but it ended up that I also had invasive cancer. And I have what's called HER2 invasive cancer, which is a more aggressive form of breast cancer. So I had a lumpectomy in June, sometime.
It was hot.
It was hot. They didn't remove all the tumor, so I had another lumpectomy. They still didn't get the whole tumor. So they said, we're going to do a mastectomy, but we need to get you started on chemo right away. So normally they will do a mastectomy first and then do chemo. But with me, they did chemo first. So I started chemo in July and I finished in November. And then in January, I had a single mastectomy of my right breast. I'm still getting what's called targeted treatment for the HER2 part of the cancer. So about 10 years ago, there was this amazing development for this type of cancer because it really, if it comes back, it's not a good thing. And so this treatment that I'm getting really reduces the chance of reoccurrence to a pretty great percentage. They can't bring it down to 0, but they can bring it down to about 10 to 15%. I'm still getting those treatments through August. It's very well tolerated, so I'm back at work full time. I don't have, sometimes I'm tired, but, if there's some skin reaction, but other than that, it's great. And it's a pretty huge advancement. So in between surgeries and chemo, as Eileen alluded to, there are a ton of other appointments. I think in 2016, I added up and I had over 100 billable medical appointments.
So we'd like to hear about the individual knowledge, practices, mindsets that you two have and how those impacted your cancer experience. For both Aline and Daisy, I think this started with their decision to be public about their diagnosis. So Aline, can you start by talking about that?
Yeah, this took some soul searching to kind of get to the root of why I did what I did. First of all, as most of you know, and many of you know very well, I'm not a very good secret keeper. I think the other reality is when you're losing your hair, you really can't keep it a secret that you've got cancer. But the other thing is that I wanted to still be normal. And there's something about having the cancer experience that it's all about being a cancer patient. And I wanted to still be Eileen Marr's public health professional. And so part of being Eileen Marr's public health professional was to do what I could to be as me as I could be. So that was probably part of the reason that I was very open about my experience from the very beginning. Daisy, how about you?
So I'm a pretty private person. I think those of you who know me can probably attest to this, especially at work. I've had a pretty hard line between personal and private. So I chose to be public about this primarily because I hadn't made that choice before. And being private is a double-edged sword. I feel like I protected myself from, I'm not really sure what, but you don't get the help. So I made the decision pretty much right after we came back from the radiologist. We sat in the parking lot, Laura and I made a bunch of phone calls. And so is it hard to be vulnerable? Yes. Is it worth it? Yes. And I really hope that, because it was worth it for me, I hope that being vulnerable with you can help you be a better friend or coworker or partner or even more gentle with yourself if you ever go through something like this. So that was also one of the reasons.
Daisy is very private, and there is quite a line between her private life and her work life. And as a matter of fact, I didn't even know she worked at the Department of Health. We were together for 10 years. I was like, we could have been sharing a ride. Yeah, who knew? See how much I trust you that we didn't rehearse this. So there is no black cloud that doesn't have a silver lining. Okay, so what surprised you both, or what did you learn about yourselves in this process? And Daisy, can you start?
So I think one of my biggest learnings, this might be my longest answer, is really about the power of self-talk and also about owning your own experience. There are a lot of predetermined scripts about cancer, and I didn't really realize that until I was in it. One being that, breast cancer does have the loudest voice. There's not a lot of advocacy work going on about other forms of cancer. Also a double-edged sword, because with the loudest voice comes a lot of things that I feel like I'm supposed to feel or do or say or adapt or adopt for me. One of those things, for example, is that I hear these things a lot from people who, as far as I know, do not have cancer or have not had cancer, like chemo is poison. And for me, I was terrified to go through chemo. I actually said, I think, no. I don't think I can do this. And I really had to think of chemo as what I believe it to be, which is a medicine that I'm hoping is going to help me live a longer life. I can't think of it as poison. And so when people tell me chemo is poison, it's hard. The other is being at war with cancer. I don't consider cancer something foreign that's in me. I think it's my cells that are actually doing their job. They're just kind of making a mistake, frankly. And I want to embrace those mistakes and be gentle with my body. And I can't be at war with my body. The other obvious thing I didn't do, but was expected of me by my healthcare team and society, I feel like, was I didn't have reconstruction, and I do not wear a prosthesis. One of the reasons was, I thought unicorns and narwhals were really in right now. Bring it on. Seriously, once I learned I was going to have a mastectomy, I spent a lot of time reading and thinking about it. This wasn't a decision that I knew going in what I was going to do. But after going through chemo and after going through 4 surgeries when I'd really never had a surgery in my life, one, I was done, if I could be done. I asked my oncologist, is there any medical reason why I need to remove my other breast? And she said no. She said it's healthy tissue. There's no reason. And that sold it for me. I'm also not ashamed of my body, and I'm not ashamed that I had cancer and this is what happened. So I don't really have a need to wear a prosthesis. And the interesting thing that happens is that actually once you have a mastectomy, you have to wait 2 months to get fitted for a prosthesis anyway. So pretty much you have 2 months of your life where you have to figure something out. And after that 2 months, I just thought, well, what's a situation? I'd already been back at work, been going to Fred Meyer, doing all the things I normally do. What was going to be a situation I'm already married, that would be any different where I would choose to do this? And I couldn't think of one. And so I never made the appointment to get one. Insurance will pay for it. Insurance will pay, frankly, probably to have my other breast removed if I needed to, or if I wanted to, but I don't. So one thing I've never had is a visible difference before. And it's been a really interesting experience, and it really hasn't always been very easy. But I feel good about myself, and that's why I did it.
And I'm just going to take a little bit of a different tact here. I have for my whole life wanted to do daily meditation and do yoga practice and all of that, and I just never quite achieved it. So then I was really, really sick. I was an extremely sick individual. And I was laying there thinking, man, I really wish I had cultivated those kinds of practices, mindfulness and yoga, because it really would have given me some, I think, peace and strength as I was going through being really, really sick and being very afraid about, not only was I going to survive, there were times I didn't think I would, but also, while I agree with Daisy about chemo made me super, super sick too. So it was always a situation, oh no, I have to have chemo now, and I know I need to. I was trying to do positive affirmations about that, but I also knew I was going to get really sick. I really want to also give a shout out to Daisy for this, because it seemed like every time I did a super trough, I would get a text from Daisy with, hey, I found this really good book, or I found these CDs, and I would immediately order them that moment. The amazement of Amazon. You're not feeling good, you can still lay in bed and order things. And so all of that really helped me, and that's what I'm trying to do now, is to think about those practices that I wish I had had when I had this experience.
Okay, this is also about interpersonal relationships and their influence on your health and your experience. Many people have asked all of us questions about what was helpful and what was unhelpful. So I thought maybe all three of us could talk about this since it is interrelated. And let's start with Daisy.
Well, first, I had an amazing caregiver, Laura. One of the great things that she did, which I've seen other people do, is she sent out updates to a big list of our friends and family, letting them know what was going on, sending pictures. And we had also pulled together a chemo drawer where Laura would give people prompts like, send cards that tell us your favorite joke, and then we would put them in the drawer so that after my chemo I had something to look forward to, because it was awful. And when we felt sick, Laura and I would sit and read all the cards, and it was really helpful. I've seen other people use the website Caring Bridge for this, which I think is a very similar thing, and also something I participate in for others, and I think it's a wonderful resource. So it's essentially a similar thing. Also, I really cannot say enough how helpful it was to get a card, a text, an email, a phone call, acknowledgement in the hallway from some of you, all of you, especially when it was really clearly stated that I didn't have to respond, that there really wasn't any expectation. Because it's not that I didn't want to respond, it's that I had no capacity and no energy to do that. And I just couldn't maintain or sustain relationships in the same way for that period of time. And so when people would say things like, well, just tell me when you need me, I couldn't do that. Things change so rapidly for me. So one minute I'd feel tired, the next minute I'd feel fine, that my appetite changed, everything changed. And so I really didn't always know what I needed. And for me, I think the very best thing you can do for someone with cancer is to just reach out. And it can be very imperfect, but don't wait for that person to say what they need. Just reach out and do whatever feels right in your heart to do, because to me, I appreciated every single thing, and it didn't matter. And I feel like sometimes fear stops us. Like, what if I say the wrong thing? What if I don't give the right gift? And I guess I would say stop and think about what you're really afraid of. Because I was not judging. Not judging the love. And once when I was out shopping after I lost my hair and I was out with my brother, and a complete stranger came up to me and said, "I hope you don't think this is creepy, but you are really beautiful." And I cried. It meant so much to me. I mean, was it perfect? No, but it was so sweet that this person thought I was beautiful when I felt awful and in the middle of a really difficult thing. Another big interpersonal lesson I learned really was about empathy. Many people I will say several people when they found out I had cancer told me about people they knew who had cancer, many of whom had died. And that's really hard to hear. At first I was really kind of incredulous, and then I thought, well, you're really just trying to connect with me. I mean, this is your experience, and you're really trying to have a personal connection. And then I realized I've probably done that too. And so I've really taken in this lesson about empathy, to me, is about recognizing that connection internally, and then really being intentional about what I actually say to that person. It may not be the whole story, it just may be like, this is what I learned, or this is what I felt, and that's what I express. And there was this woman named Emily McDowell who had cancer, and shout out to Emily McDowell, she just created her own line of empathy cards, and Eileen has one of them. But one was based on this experience, because she had the same experience. And it says, "When life gives you lemons, I won't tell you a story about my cousin's friend who died of lemons." I love that.
Or do you want to go just to talk, or do you want me to go next? Oh, okay, I'll go ahead and go next. A couple of things that happened to me. One of them is I got an amazing email from Joan Brewster, which was about the fact that her sister, many of you know her sister had a lot of challenges with cancer, and Joan ended up doing a bone marrow donation, and her sister is doing great, and she talked about how she was biking in Hawaii with her grandchildren, and it was just that was exactly what I wanted and needed to hear. The other person I need to do a shout out to is Kathleen, because she came to my house the day I heard that I had stage 4 cancer and brought this amazing multi-balance bracelet that I wore every moment throughout the process that reminded me to stay balanced and hopeful. I agree with Daisy, the card thing is amazing. I bought a stack of cards, I looked through them again last night. I heard from many of you in this room, which was wonderful to hear from all of you. And then the C4PA crew did cooking, and Kristen Peterson delivered it, and that was perfect because the energy just isn't there to take care of those types of things. So all of that was really helpful. I think what wasn't terribly helpful, in addition to what Daisy said, is the fact that people still expected me to be a nurse. And the reality is I was a patient. I wasn't a nurse anymore. And so the hospital would get, "Oh, you're a nurse." No, I'm really not. I'm a patient. Yes, I am, but not today. So that ability to just actually not be expected to be a nurse, and frankly, not to be expected to be anything at any given moment in time. The other thing I wanted to say is, the whole, and we'll get into this, I think I'll actually do this one when we get into some other stuff. Okay.
So my experience as a caregiver was no different than millions of other caregivers. the courage of the person that you're caring for really keeps you going. And that's so true with Daisy, and I don't want this gossiped about in the hallways, but Daisy's pretty easy to care for. Working at the same agency had its benefits and drawbacks. The benefits, of course, were the expressions of love and caring from my own friends and coworkers, and from Daisy's too. So I had a huge extended family, and I have never been so hugged or well-fed in my life, and I actually did gain 12 pounds over the last year, because although Daisy didn't always have an appetite, I did. So all the baked goods and home-cooked meals were thoughtful and delicious. My team at work was amazing. Maria and Tiffany and Mary Beth and everyone. And just people throughout the agency. It was really almost overwhelming, the amount of support. And I just want to say you will never know what a difference you made for us both. And we just thank everyone so much, because you know, there's always a hard night before, and you come into work in the morning, and just a word or a kind thought just makes such a difference, especially from people that you don't know. And that happened quite often, and I have one story I must tell. Usually it was really nice, but one time this woman came up and gave me a hug and said, "So you're married to Daisy Orr?" And I said, "Yes, I am." And I had never seen this woman before, and she went, "Huh." Walked away. So I'm interpreting this as, how lucky for Daisy. But I guess I'll never know, since I have not seen that woman since she was not in this room. Anyway, as a caregiver, you get so caught up in all the schedules and appointments and medications and all the business of the illness that the most helpful things that people did for us were when they just did stuff. I've been guilty of saying things like, "Let me know if I can help," and that's a standard line that I put in dozens of get well cards, and I always mean it. But I never really understood before that what's most helpful is when someone just says, "Hey, I'm going to come and feed your cat," and then does it. So any kind of small thing that a caregiver can check off their list is just like a miracle, because the list is so huge. And I think the thing we both learned in this experience is that we really are the luckiest people in the world, and the most grateful people for all of the support. And that includes not only on a personal level, but also on a system level. So bringing it back to public health, we're going to move on to talk about the influence of organizational practices and policies. And I think Aline is going to talk about the Department of Health, and Daisy will talk about healthcare. So Aline, do you mind kicking us off about policies that help care at the Department of Health?
It's really a long list, but I think it really starts with that whole ability to bring your whole self to work and to be authentic, because I was able to work through much of this process, and to be able to do that in such a way that I could work as much as I could, and that was okay, and to be able to, not work when I was unable to work. So that was really positive. I think it's also important to think about the concept of a state family. And you hear that a lot, and I experienced that state family when I was sick, which sometimes we don't always think about or appreciate as much as it helps to, until you really need it. And man, I felt that the state family was here. Also being able to have shared leave, being able to have, be able to take FEMLA. All of that was incredibly critical, because I couldn't worry about all of that and possibly take care of myself and begin to get well. I think on a really practical note, a couple of things are super important. We mean it when we say stay home when you're sick, because if you're sick and somebody's immune compromised, it's not good. The other thing is we have scent-free guidelines. I think they're very important as well, because when you're having chemo, scent is incredibly challenging. I mean, I couldn't use a scented product, and if I smelled scent, I really had a hard time with it. So those guidelines are important for a reason.
I agree with you. There was a couple things in the healthcare system that I experienced that were really helpful. I got all of my care through Kaiser, or Group Health, now Kaiser Permanente. So I want to talk a little bit about a helpful clinical practice and then a helpful environment. The clinical practice was really my surgeon, who I believe would really practice holistic care. I found out later he actually went through cancer himself. He spent, I think our first appointment, he spent 2 hours with us. He wanted to make sure that we were we understood what was happening. He drew diagrams, sometimes on his scrubs, whatever was available. And he was very not only concerned about my physical health and about the surgery, but he was the first person who said to me, you really need to get your head around this emotionally and mentally, and you need to take time to do that. And coming to me from a surgeon, a general surgeon, was remarkable. The other helpful environment was the infusion room. I don't know how many of you have been in an infusion room. I have never been in an infusion room until this. I really think all healthcare should be like an infusion room. So it's where I got my chemo. It's where I continue to get all of my treatments. It's a large room like this. The nurses are in the center. You sit there's no privacy. You're right next to each other. My chair would be right next to Eileen's chair, which was great because we got to talk to each other. My first chemo, I was in the chair for 8 hours. And there were people to talk to. And inevitably, although I've heard an oncology nurse say that everyone says this, I felt like everybody next to me was worse off than me. But the oncology nurse says everybody says that, which is interesting. The other thing they do is the oncology nurses, to me, are the best nursing care I've ever received. They have something where, some type of training or personality where they are able to keep calm in the room no matter what is happening. There are emergencies happening and they are calm and efficient. And they bring you a warm blanket and a pillow. And there is something so physically comforting about that, but so emotionally comforting about that, to have someone just, let me bring you a warm blanket and a pillow while you're here and you're scared and you're going through something that is not making you not feel very well. So I really hope we can apply this model in other ways.
You'll do almost anything for a pillow and
a warm blanket.
So let's move on to the influence of community. And you both live in different places. Did either of you find resources in the community to be helpful? And we'll go to Elaine first.
I really didn't have the energy to take advantage of much of what was available to me. I got my care at the Seattle Cancer Care Alliance. You know, my oncologist, I think, took a shine to me because I believe I probably reminded him of his mother, who also had lymphoma. So we had a mother-son relationship with my oncologist. But Seattle Cancer Care Alliance has a plethora of resources available. You know, it's a one-stop shop for diagnosis and treatment and support groups and housing and financial assistance and virtually anything you can think of. Social workers, spiritual guidance. So it's an amazing place, and every time I went there, it was an amazing experience. And it's illuminating to see how many people have cancer at any given moment in time and where they're at on their particular experience. But again, they were there, I just didn't take advantage of it. But thinking about that, it's an energy issue, and it's also the fact that I had an amazing caregiver, and I had a lot of friends, and a lot of that really helped me feel supported.
So I had a similar experience in that I didn't feel like I took advantage of a lot of community resources during treatment. We did create a resource list that was out there by the T of just from our own experience, doesn't affiliated with DOH or in our healthcare agencies, but not only of the books that we both found helpful, but some of the community resources that I know I used later. The one I used while I was in treatment was Providence. Does have some integrative medicine. I did go to a nutrition class that was helpful. They also had an amazing geneticist, so I did get genetic testing. I do not have any genetic component to my cancer, but the care I got from the geneticist is incredible. So a couple on the resource list out front, if you didn't see it, Harmony Hill in Union does retreats for people affected by cancer for free. And I went to them probably one time in May, and then I've used them later. And the other is yoga. So there is a Yoga for Healing class taught at the Yoga Loft here in Olympia, taught by a breast cancer survivor. That is all about how to help your body really heal from cancer. And that's been pretty incredible.
So the outer ring on the model is state influence, and we see this in terms of policy, culture, and so forth. While everything the two of you have said really does come back to public health, this may be the place where you have something more specific to share about public health and this experience. Daisy.
Okay. So again, I just want to reiterate that this is one perspective. So the first thing that really came to me was around health equity, and Laura mentioned this a little bit before, but it was very humbling how complicated the cancer process and experience is. I mean, the number of appointments I had, the number of tests I had, the systems that did not talk to themselves, each other. I mean, the pace is intense, and I feel like I'm a well-resourced, well-supported person. I was probably in the absolute most supportive place to me I think a person could be to have cancer, in terms of my workplace, all you amazing people, my family, my friends, the practices I had going in, and it was still really, really hard. And so I think about people who do this with even one of those things being gone, and it breaks my heart. Because I know there are many, many, many people who go through this with very little support. And I do think that's where those community clinical linkages can be so, so important, and the practices in healthcare can be so important. A couple other insights I had about the work that we do. So, I mean, I am a trained health educator. I was been in this field for a while. I was trained in this field. I was trained in prevention. And even I had self-talk and self-blame about cancer. And so it made me think about how can we do a better job of balancing our messages of prevention so that we're not implying blame, and also that, so I am not a smoker. I was not a smoker, but it really should make no difference about the amount of compassion that you give me if I have cancer. And I feel like when we try to figure out why this happens to somebody, and so we go through, and I know I've gotten asked the question, and you probably have too. It's like, what did you do? Or what didn't you do? And the self-talk is really, really strong. And for me, I mean, I had the thought like, well, I guess I fell off the prevention train because now I got it. Like, I failed. I know that's not true, but I hear the message in my head, and I'm in this field. And so I guess I feel like, how can we help people live the healthiest lives they can live and still have compassion for whatever befalls them, no matter what they're doing? And the other insight I had that I shared at one of our leadership team meetings when we were talking about our own strategic plan about prevention of death was, can we move to thinking about prevention of suffering? and promoting quality of life. Because some people are not going to live as long as other people, and we still want them to have a good quality of life, and we still want to reduce their suffering. And prevention of death had a different ring to me when I felt like I was facing my own mortality.
Daisy and I have talked a lot about the whole blame thing as we've had our numerous conversations over the last number of months. The other thing I wanted to talk about in the policy area is the whole access to health insurance. Cancer is extraordinarily expensive, and I imagine it's one of the highest cost conditions out there. And people who are uninsured, I cannot even imagine what they would have to go through in order to get treatment. And like I said, we're talking, I don't even know what my total treatment cost was, but a person who wasn't insured would not even be able to look at that and be able to, maneuver through the system. I think another thing that we need to pay a lot of attention to is the whole issue of making sure pre-existing conditions are covered. I'm fortunate in that I'm going to be eligible for Medicare in about 6 months, but think about people who have had cancer and lose their health insurance and then can't get health insurance at any kind of an affordable cost because they have now a pre-existing condition. So I think that's another incredibly important policy issue for people with cancer and others.
Okay, well, this is the end of the formal presentation from Daisy and Aline, and I know they tried to answer questions within the presentation, but we do have some time, so if people have questions or stories that you'd like to share, this is a great time to do that. And I think we only have this one mic, so if you let me know where you are, I will come at you with a mic.
Thank you. My name is Rick Ordos. My wife went through Hodgkin's lymphoma 19 years ago. It was discovered she had a lymph in her neck, so it made it to 2 weeks after our son was born. But during the long process, figuring out exactly what stage and what that was, you get to the stage where you talk about treatment, and then the physician gave us options, and which just floored us. It's like, well, it's your choice. Did either one of you have that, and how did you react to that?
I had no options. Mine was super aggressive. It was get in, get treated, or you wouldn't survive. So no choice for me, but Daisy.
Thank you. What was your name?
Rick.
Rick. Thanks, Rick. And thanks for sharing about your wife. I did have some options. The main one, well, I had an option that was presented to me, and then I had an option that I felt like I made for myself. So, because I decided chemo was an option. According to Laura and my mother, it was not. But in terms of having surgery, there is an option that was presented to me as a surgeon from my surgeon of, how interested are you in saving as much of the breast as possible? Are you really nervous? Do you want me to take the whole thing off right now? So there was just sort of like, we don't really know. There's this tumor there. We don't really know how big it is. I mean, we know approximately how big it is, but until we get in there, we don't really know much more about it. And so I decided early on that I wanted to just go from what was least invasive to me as possible from a surgical standpoint. And so that was the reason for having the 2 lumpectomies before having the mastectomy, instead of just going straight there. Because at the time, he felt like that seemed like that was something that we could do. But maybe like you, I also was pretty clear with my oncologist and my surgeon that this is what you do, and I really want your recommendation.
She's fine, by the way.
Good.
Did you ring the bell?
Did you?
I did, yeah. So I went through the same, I went through treatment at group health. And at the end, they have a bell that people ring when they finish their treatment. And my last treatment, I remember I was just so anxious to get out of the doctor's office and go ring the bell. And I said, I'm going to ring the bell. And she didn't even know, she didn't know about it, you know. So I turned around, she was standing behind me, because she could tell how important that was, you know. But to get to that point, so, and I totally agree with you, Jeff and Audrey and Beth.
They're gonna let me ring the bell twice. Because I'm not done yet. I was done with chemo and now I get done with my second, so I asked if I could ring it.
I can totally. It really, it's huge. I can totally see that conversation.
The negotiation.
Not so much a negotiation. Other questions or stories? Comments?
First of all, thanks for sharing your stories. They're incredibly important to do, and I know this was one way of your giving back to folks, so thank you for that. The question I have for you is for those of us who are supervisors. This comes up where you have someone who's ill, and has happened a number of times, and as someone who's a supervisor, I always feel, so this is giving your feedback to me, a little bit about how do I help protect the employee. Public health folks are so giving, and clearly you have appreciated that. But I know that for folks it can also get really overwhelming, and there's points at times where it's like, look, I can't take a visitor, or no, I don't want people calling me. So I've always sort of felt one of my roles was to help play gatekeeper for folks in trying to understand what you need. And I know you said it's also sometimes hard to say if you know what you need. But so as supervisors, what advice would you give us to help sort of to be the most helpful? And again, I realize people's experiences are different, so these are general from your perspective.
I can work off part of the 12 pounds.
Counting steps. I think, John, like what you did, calling Rick, calling my husband and checking with him, and not, sometimes I would answer the phone, is really helpful. And I also think that's where things like texts come in. Sending a text, sending a card, but sending a text is really good. Then you, as the recipient, you can kind of say, this is where I'm at right now. You know, yeah, I'd like to talk, or no, I can't talk, or I'll talk with you later. So text messaging worked really well for me. And also, I assume you probably had conversations with Laura, or Jana probably had conversations with Laura to see how he was doing. And that, I think, helped a lot. So, like, for me, at work, having Kristen kind of knowing what was going on, living nearby, and then being that person who could keep people informed was helpful.
Dan, who was my immediate supervisor, was incredible, and I felt like I just didn't have to worry about anything. I tried to be really clear in talking and telling Dan or telling Jana what was going on, that this is okay to share, and please do, because if you share it, then I don't have to share it. And so they both really sent messages out. I know, talked to my staff, told them what was going on, and I find that incredibly helpful. And I do think that is one thing those of us who are experiencing something can do to help the supervisor, I hope. And then maybe Dan or Jana want to speak to this, but so that part I felt like worked out well. The role of gatekeeper is interesting. I hadn't really thought about it that way. But I do feel like just checking in, which both of them did periodically, and then really making sure that the people that reported to me were supported, which was the thing that I was concerned about, that they didn't feel, this I mean, again, it's sort of arrogant thinking, but that they didn't feel lost or whatever, but they're great, they just get going, so. Jana or Dan, is there anything you want to say?
Sorry to put you on the spot.
So for me, I was about 42 when I was, the oncologist told me I had bladder cancer, and so I used a lot of what drew from my experience. I worked with a lot of young folks at the time, and they treated me like I was an outcast, didn't know what to do, didn't know what to say, left me pretty much on my own, and what I missed a huge amount through my experience was the connections with folks and the wanting to have, to share what I was going through and to be able to let my staff know what I was going through and that I was thinking about them and hopefully to hear that back. I hope that experience was what I drew from was helpful for Daisy as she went through her own process.
Any other questions or thoughts? Or stories? Okay.
Do you want to check?
Oh, okay.
I have one more thing to say, and it goes back to organizational practices that I've got. I had more blood transfusions than I can count. I have no idea how many I actually had. And another organizational practice we have is having the ability to donate blood at work. That is a really wonderful, wonderful thing. Please take advantage of it.
I just want to say thank you. So thank you all for being here. We really appreciate it, being able to share.
The sun, it does not cause us. The sun, it does not cause us to grow. It is the rain that will strengthen, the rain that will strengthen